Hey everyone, welcome back to the channel. For those who are new here, I'm Dr. John Barbieri. I'm a board-certified dermatologist and acne and rosacea expert. Here today, I want to do a little bit of something different. I'm going to go through something based off of a talk I gave at the American Academy of Dermatology annual meeting, where I discuss controversies in acne and rosacea. We'll discuss topical treatments, pill medicine, systemic treatments for acne and rosacea, lab monitoring, and side effects. We'll go through some of these controversial topics. We'll review the evidence, and I'll share with you how I think about approaching these. I want to start with talking about the potential relationship between isotretinoin and Accutane suicide and depression. There are certainly lots of case reports of people wondering whether isotretinoin might have caused mood changes or other issues. And so what does the evidence tell us? When we look at depression, isotretinoin appears to be associated with improvements in mood. There's reduced risk of depressive symptoms, reduced risk of taking antidepressants or being hospitalized for depressive symptoms when we look at people who are treated with isotretinoin compared to other acne treatments. And these are large meta-analyses combined together, lots and lots of big studies. In addition, there was a recent meta-analysis looking at suicide. This again, it looked at 24 studies, over 1 million individuals. And what they found is that isotretinoin was associated with a reduced risk of suicide compared to other acne treatments. And they also didn't find any evidence linking isotretinoin to other neuropsychiatric side effects. However, there are important lines of reasoning that suggest that individual people do experience mood changes with isotretinoin. Vitamin A, and isotretinoin is a lot like vitamin A, is associated with mood changes. Isotretinoin and Accutane can affect areas of the brain like the hippocampus that might be important in mood. And then most critically, if you give someone isotretinoin and they develop mood changes, when you stop it, it often gets better. If you give it to them again, the mood changes come back. And that challenge the challenge kind of case series evidence is very suggestive that isotretinoin is what's causing those symptoms. So how do we put this all together? We have these large population-based studies that are suggesting no risk, but then we have these smaller case reports that are suggesting risk. What does this mean? So the way I would kind of frame it is, I do think isotretinoin is associated with rare, unpredictable, idiosyncratic, we doesn't know really who it happens to, meaningful negative effects on mood. This could be irritability, mood swings, depression, even potentially suicidal thoughts. However, on average, isotretinoin improves mood compared to other acne treatments, likely because it's so good at treating acne. And we know untreated acne is associated with depression and suicidality. And so my take-home point here is we shouldn't be afraid to use isotretinoin, even in people with a history of mental health issues. In fact, these might be the people who need it the most. And so we should be vigilant. We should monitor for these rare potential side effects of isotretinoin, but we shouldn't be afraid to use it for patients who need it. What about lab monitoring with isotretinoin? Do we need to check labs? Well, when we think about lab monitoring, the goal should really be to prevent some sort of serious side effect or to help us guide dosing, figure out do we need a higher dose or a lower dose. And there are downsides to lab monitoring. There's pain, it hurts to get your blood drawn. There's fear, not just of the blood draw, but it makes the medicine sound scary if it needs lab monitoring. And of course, there's cost. And as patients increasingly have to bear the cost of their healthcare, this is an important factor to consider. So let's look at the data for isotretinoin and lab side effects. When we look at lipid changes, seeing meaningful, really high elevations are rare. They're not zero, but they're quite rare. And in fact, many of the patients who develop them just continue their course of isotretinoin. They get rechecked and they're normal. Importantly, it doesn't appear that checking these lipids will help us avoid pancreatitis. That's why we're doing it. We're worried that high triglycerides might increase the risk of pancreatitis, and we're trying to prevent that severe potential side effect. Well, first off, pancreatitis with isotretinoin is extremely rare. There have been very few cases reported. And notably, in those cases, only 10% of the people had high triglycerides. So if we're checking triglycerides to try to identify people at risk of pancreatitis, and first off, it's rare, and second, it doesn't seem like the triglycerides predict this. Is that actually a helpful, high-value practice? What about liver tests? Well, here we actually see that abnormalities are just as common before you start the medicine as on treatment. And that's kind of suggestive of background noise, that it may not be actually related to the drug. And again, if we think about just, does anyone have severe liver side effects? There really have not been any notable cases reported. And so if LFT abnormalities seem just as common at baseline as on treatment, kind of that background noise signal, if there don't seem to be really clear, true, lasting hepatotoxic liver injuries from isotretinoin from Accutane, is this monitoring of high value? And then when we look at complete blood count monitoring, looking at white blood cells and platelets and those things, there just don't seem to be meaningful abnormalities that occur with any regularity. So now we have a Delphi consensus that kind of takes these type of data and puts them into practical guidelines. And what we recommended in this Delphi was to check labs at baseline and at peak dose, and really just to check lipids, triglycerides, and AST/ALT. And I would argue honestly that we potentially could offer no monitoring to a patient after discussing risks and benefits, because again, it doesn't seem clear that it helps us achieve those goals of guiding dosing or preventing side effects. But I certainly think reducing our monitoring to just checking labs at baseline and peak dose and just focusing on LFTs and a lipid panel, not checking complete blood counts, is a reasonable place to start. And if we did this, just looking at our current practice in the US to going to this new proposed practice, there's savings of millions, hundreds of millions of dollars a year are possible. And again, reduce fear for our patients, reduce unfunness of getting their blood drawn. So a bunch of benefits to potentially making this shift. Changing gears a bit, what is the best topical retinoid for acne? We have a number of different topical retinoids now, and a common question is like, well, which one should we use? Is it adapalene or tretinoin or some of these newer ones like trifarotene? Which one's the best for acne? Well, unfortunately, we don't have a lot of head-to-head studies. It would be great if we had like, here's tretinoin versus trifarotene. Let's see which one's better. We don't have those studies really. So we have to do the next best thing, which is called a network meta-analysis, which is, let's say we want to try to compare tretinoin and something like azelaic acid, and there's no study that compares them. Well, there's a study that compares tretinoin and adapalene and adapalene azelaic acid. So we could try to use these networks to kind of make our best guess of how they might compare to each other. When we do this is a study from the UK looking at some treatments they have available there. We see that kind of when it comes to which one seems to work the best in terms of effectiveness, these fixed dose combination treatments like adapalene benzoyl peroxide or clindamycin benzoyl peroxide work very well. Then adapalene and tretinoin pretty similar to each other, and then things like topical antibiotics. But of course, this is missing some treatments. What about trifarotene or tazarotene or these new formulations? Where do those fit in? Well, let's look through some of the data. So let's start with trifarotene. This is a 4th generation retinoid. It's highly selective for the retinoic acid receptor gamma. The idea is that maybe having this selectivity is going to help improve effectiveness and reduce side effects. Well, does that bear on the data? It certainly works well. These are the phase 3 trials. It has good rates of IgA success. It works a little better for whiteheads and blackheads than inflammatory papules and pustules, and that's often what we see for topical retinoids. There's also data that's helpful for acne on the trunk, so that's all really nice. But then how does it compare from a standpoint of tolerability, right? It works really well, but is it more irritating? Well, when we look at the phase 3 data, a lot of people did have moderate or severe redness, scaling, dryness. And in this head-to-head study looking at irritability, trifarotene was much more irritating than tazarotene lotion. It also looks like it's more irritating than adapalene. So now we have this kind of challenging thing. It seems to work pretty well. It definitely has a signal that is more irritating than other retinoids. Can we help contextualize this more? And that's where, again, these network meta-analyses can help us. So here's a network meta-analysis of 221 different trials, and they do actually compare trifarotene to other topical retinoids. When we look at effectiveness, although those phase 3 trial data look pretty good, when we compare it to other acne treatments, it actually doesn't look like it's any better than them. It might even be worse than some things like tretinoin and tazarotene when it comes to IgA success, getting clear, almost clear skin, or reducing pimples. And as I mentioned, I was worried about side effects, and this network meta-analysis kind of confirms that. It's the most irritating topical retinoid in this network meta-analysis, much more irritating than adapalene or tretinoin, and even more irritating than tazarotene, which we often think of as a more irritating topical retinoid. And so we really do need some more rigorous head-to-head studies to try to understand, does trifarotene have a place in our treatment of acne? Because when we look at these data, it seems to be the same or less effective than other retinoids and more irritating. So not a clear, good use case, but there might be some, maybe truncal acne. Maybe we do a head-to-head study versus tretinoin and it shows that actually on the trunk, it's not so irritating and it's very effective. So we need those head-to-head studies to understand if it does have a place. But for now, it doesn't seem to have a clear role when it comes to managing acne. What about these lotion formulations of tazarotene and tretinoin? The idea here is if we can get the medicine to be released more slowly on the skin, it might be less irritating. And this is a really nice idea. In fact, when we look at the phase 3 trials, it seems to work. When we look at tazarotene lotion, it has similar effectiveness to tazarotene cream, but it's half as irritating. And so we are able to use these lotion formulations to reduce irritation while maintaining effectiveness. So for those who have sensitive skin, this can be a really nice option. There's now also this encapsulated tretinoin and benzoyl peroxide. The idea here is if we microencapsulate it, we can combine them. That's the first challenge. And maybe it improves tolerability like what we see for encapsulated benzoyl peroxide on its own. Well, let's look through the data here. So when it comes to the phase 3 trials, we see really nice effectiveness. You can see, tazarotene is about 10% versus vehicle for IGA success. Here it's more like 15, 20%. So certainly better, and that's what we'd expect when we combine two effective acne things together. It works particularly well for comedonal lesions like whiteheads and blackheads, like we often see for topical retinoids and benzoyl peroxide. But how does it compare to adapalene benzoyl peroxide? We already have a retinoid benzoyl peroxide fixed dose combination. Is it better? Well, we don't have a direct comparison. Unfortunately, that network meta-analysis doesn't look at this. But if we just look at the phase 3 trial data for IGA success with adapalene benzoyl peroxide, the 0.1 and the 0.3%, again, there's about a 15-20% difference between vehicle and treatment for IGA success. Looks pretty similar to this one. So not clearly more effective than what we already have in a very inexpensive generic product. Is it more tolerable, right? I mentioned maybe that microencapsulation improves tolerability. Well, if we look at people who discontinue the study due to side effects, it's about 3% for this tretinoin benzoyl peroxide compared to 0% with vehicle. How does that compare to those adapalene benzoyl peroxide studies? Well, again, it's about the same, maybe actually a little worse. If we look at those trials, it's about 1.5–1% more for the adapalene benzoyl peroxide than vehicle. It's actually a little bit better for adapalene benzoyl peroxide than this new encapsulated tretinoin benzoyl peroxide. Now, these are not necessarily the same study design. There's not the same investigators, so it's not a truly fair comparison, but at least there's not a clear signal here that this product is more effective or better tolerated than currently available, inexpensive, easily accessible generic adapalene benzoyl peroxide. And so this is something where, again, if we're going to be using this, we really need some head-to-head studies that show that it provides some meaningful value over what we already have, which I don't think we've seen yet. What about this triple combination cream? It's got adapalene, topical retinoid, benzoyl peroxide, and clindamycin. Well, look at these phase 3 trial results. So IGA success, 50%. We haven't seen anything like that in the studies we've looked at so far. 25–30% better than vehicle. Really good for inflammatory and non-inflammatory lesions. Again, these are just some more data showing this, getting improvement as soon as 4 weeks with this. And again, that network meta-analysis, it's at the top for effectiveness. Not surprising seeing those phase 3 data. What about side effects? Well, the rate of discontinuation due to side effects was about 2–3% in these studies. So pretty similar to what we saw in those other adapalene and benzoyl peroxide and tretinoin benzoyl peroxide studies. And in that network meta-analysis, it's kind of right in the middle. It's, seems to be about the same as other topical retinoids. It's better than trifarotene. Again, that one seems to be the most irritating. And so this seems like it's a pretty good product. It's highly efficacious. It doesn't seem to be more irritating than a lot of our other topical retinoids. And it's very convenient. It's 3-in-1. So the way I would kind of summarize this is that for the typical patient, adapalene or adapalene benzoyl peroxide, those generic products seem to work about as well as anything else. And that's a good starting place. They're easy to use. They're well tolerated. For those with more severe acne or who need something that's more convenient to improve adherence and outcomes, this triple combination, topical antibiotic, retinoid, benzoyl peroxide treatment looks really promising. All right, moving on. Let's shift gears a bit. We talked about monitoring with isotretinoin. What about spironolactone? So with spironolactone, there are concerns about high potassium, hyperkalemia, and we see that frequent monitoring is a common practice. About 50% of people are getting potassium checked at baseline, about 40% on treatment. This is a high-value practice. A work from Arash Mastaghini's group has highlighted that rates of hyperkalemia are about the same at baseline as on treatment. That's, again, that kind of background noise signal that we talked about with LFT changes in isotretinoin. It doesn't seem to help us guide management. Again, that key parameter for is lab monitoring useful? There's some other studies that really show the same kinds of things. And these are 2 more studies really showing the same findings. And so that really calls into question whether monitoring potassium on spironolactone is a high-value practice for young, otherwise healthy patients. And there probably are opportunities to improve the value of care we're providing by reducing this monitoring. Now, another question that's related that comes up is, can you combine spironolactone and drospirenone containing combined oral contraceptives? There's 2 studies that suggest that this can be done safely without increasing risk of high potassium hyperkalemia. Another way to think about it is that, like, drospirenone is like 25 milligrams of spironolactone. So going from 100 to 125 milligrams of spironolactone is not a big difference. And so you wouldn't expect this to be a major issue. We now do have some exciting randomized controlled trial data that's coming out in spironolactone that I wanted to share. This is the SAFA trial. It's looking at spironolactone versus placebo for adult women with acne. And they found that spironolactone was significantly better than placebo for the treatment of acne. I think this kind of confirms what we had seen from case studies and other observational data, but it's nice to have finally a really large, well-conducted randomized controlled trial to support the use of spironolactone for acne. In addition, this helps us understand the side effect profile of spironolactone, where we can see that the main side effects are dizziness, lightheadedness, these kind of blood pressure type effects that you might expect based on how spironolactone works. It is sort of a weak blood pressure medicine. It's only about 5 to 7% more than placebo. So, about 95% of people aren't going to have a major issue with this. The other one's headache, which probably goes along again with those blood pressure effects. Interestingly, we didn't really see any issues with menstrual cycles. And I think that highlights that at these doses around 100 milligrams a day, it's typically not a problem. We do now have a topical anti-androgen, Clascoterone, which is an exciting new treatment for acne that can be used in both women and men. So now we can use anti-androgen treatment in both female and male patients. And this treatment, it works very well in the phase 3 trials. It's similar to most monotherapy acne treatments. It's about 10% better IGA success than vehicle. It seems to work particularly well for inflammatory papules and pustules. And notably, it's very well tolerated. It doesn't seem to have a signal for irritation like we see with benzoyl peroxide or topical retinoids. There is an important note from a safety standpoint that when you use huge amounts of it, 6 grams, that's a ton, that there is some potential for adrenal suppression. And these pharmacokinetic studies, about 7% of people who use these huge application amounts did have biochemical evidence of HPA axis suppression, of adrenal suppression, but nobody had symptoms or no issues in the phase 3 trials. I think using it on a smaller area like just the face isn't at all an issue. There is a head-to-head study looking at Clascoterone and tretinoin. And actually, in this study, Clascoterone, the black bar, looks like it's a little bit better than tretinoin, basically, at every time point where they evaluated it. So that's also encouraging, too, something that's similar in effectiveness. A topical retinoid is kind of a backbone acne treatment, but much more well-tolerated. And when we look at that network meta-analysis, Clascoterone right here in red, pretty effective, kind of on par with other topical acne treatments. When we look at IGA success, it's actually quite good. And from a tolerability standpoint, it's one of the best. It's much better tolerated than other topical acne treatments and topical retinoids. So this is a really helpful treatment. It can complement our other acne treatment mechanisms by being able to address hormones that affect acne in everybody. And it's very well tolerated, which is great. So for those who have more sensitive skin, I think this is an extremely valuable treatment. Moving on to talk about systemic pill medicine treatments for acne, oral antibiotics are the most common pill medicine that we use. They're used more by dermatologists than any other medical specialty. So we're huge antibiotic prescribers with much of that for acne. It's about split half and half between doxycycline and minocycline. So the first thing I want to bring up is is minocycline any better than doxycycline? Because there are some important safety concerns with it. It can cause severe drug eruptions like DRESS. It can cause neurologic effects like vertigo or other issues. And doxycycline doesn't have these side effect problems that minocycline has. And in this Cochrane review, there's really no evidence that minocycline works better than doxycycline. So I really think for the average patient, probably doxycycline is where to start. Minocycline might be helpful for those who don't get better with it or have issues with sun sensitivity. But in general, I think doxycycline makes more sense as a starting place. But what about these new antibiotics, sarecycline, right? Antibiotic resistance is a huge issue. Even a narrow spectrum antibiotic like sarecycline cannot solve this problem. Well, sarecycline is certainly more selective than other tetracyclines, which is great. So that can potentially help us avoid these side effects. It does seem to have less activity against some other bacteria, particularly gram-negative bacteria. So maybe could that help reduce gut side effects, the microbiome, or issues like diarrhea or stomach upset? And it definitely does work in the phase 3 trials. It works, much better than placebo. This is kind of similar to what we see in oral antibiotic trials. I wouldn't say it stands out as substantially better than other ones. People get particularly good improvements in inflammatory lesions, which I think is common for oral antibiotics. Less so for whiteheads and blackheads, but it still helps there. And it does seem to be well tolerated. There are low rates of stomach side effects like nausea or belly pain. There are low rates of things like yeast infections. There didn't seem to be any evidence of issues with vestibular issues like vertigo or photosensitivity, getting sensitive to the sun. But again, we really don't know how it compares to these other antibiotics. I definitely think it has a ton of theoretical advantages, but in real clinical practice, these translate into meaningful benefits for a patient. I think they still need to see that. We need those active comparator studies to see, does it have better effectiveness? Is it easier in terms of side effects? Does it have less impact on the microbiome? Now, the other thing that comes up for trying to address these issues of antibiotic use is this low dose idea, this submicrobial dosing. And does that actually work? There's some key assumptions here that one, these doses are below the minimum inhibitory concentration, and then that's a good thing. And do the data actually support these assumptions? Well, first off, it's unclear that actually these doses are below the minimum inhibitory concentration. This is kind of the classic figure that gets shown to support this, and it goes, look, doxycycline is above it. This lower dose, 20 milligrams twice daily, is below it. But they don't actually say what bacteria this is. And as we saw with sarecycline, these minimum inhibitory concentrations, they depend on species. So this might be true for some bacteria, but maybe not all. And it might not be true in other places, like in the gut before it's absorbed and distributed through our body, the concentrations might be much higher and above MICs. And we know that oral antibiotics are associated with risk of inflammatory bowel disease and colon polyps and colon cancer. So it is important to understand in the gut, is it actually below the MIC? And we don't know that. Then finally, the next thing is like, is this good? And in fact, in vitro, doing these kind of lower dose below the MIC kind of antibiotic exposures actually creates resistance because it gives a little bit of selective pressure, but it doesn't kill them. If you ask like Alexander Fleming what he was worried about penicillin was people underdosing themselves, and we're intentionally doing it here. So that might be an issue. And then finally, like in vivo, what happens? So when we use these low-dose regimens, I love this study title, does not lead to changes in antimicrobial susceptibility. Well, after 12 months of low-dose doxycycline, it seems like even just 20 milligrams a day, this yellow bar is changing the MIC of these Actinidobacter compared to placebo. Something is definitely happening here. This is another study looking at staph and strep resistance, and even doxycycline 20 milligrams a day, we're seeing staph and strep resistance develop. So for me, these low-dose antibiotic regimens, they do have less side effects. They're easier on the stomach. I do think that's a good thing. They can absolutely help with treating acne. I do think they have a role. But this idea that like low-dose antibiotics, we don't have to worry about antibiotic resistance or other issues, that's just not what the data really suggests. And so for me, I don't like this term submicrobial. I think it's falsely reassuring. I call this low-dose antibiotic regimens. And certainly they have advantages, but they're still an antibiotic. They still exert selective pressures. They can still disrupt the microbiome and cause antibiotic resistance. So then how do I put all this together, thinking about sarecycline and low-dose regimens? For me, the main goal is to try to limit the number of people I treat rather than duration. When we look at microbiome changes, they can happen as fast as 4 weeks after starting isotretinoin, and starting oral antibiotics. And to be honest, these 3 to 4 months in the old guidelines are really arbitrary. It's not like a 2.9 months, nothing bad's happening, and 3.1 months it happens. These things happen quickly. More exposure is obviously worse, but it's not like if you hold it just 3 months, something great happens. For me, doxycycline 100 milligrams twice daily is the main antibiotic I use. It seems to be similar in effectiveness and safer than minocycline. I do use lower dose regimens for those who have side effects or to help get off of it. And I do think sarecycline is a helpful antibiotic for those who might not respond to other ones, who have comorbidities like gut health issues, or where we're stuck with more long-term use where we just can't get them onto another treatment. All right, I'm now shifting gears again. I want to talk about rosacea. So is there a role for benzoyl peroxide in rosacea? We think of rosacea as sensitive skin and benzoyl peroxide as irritating. Could you use benzoyl peroxide to treat rosacea? And the answer seems to be yes, if we encapsulate it. That's the key thing there. So if we look at encapsulated benzoyl peroxide, again, that gets distributed more slowly and gently on the skin, we find that it's very effective. Look at these nice rates of IGA success, about 50% with the benzoyl peroxide versus 20 to 30% with vehicle. And notably, in terms of side effects, it doesn't seem to be that much worse than vehicle. It doesn't, you don't see people discontinuing it, about 1% more than vehicle. So many people are able to tolerate this encapsulated benzoyl peroxide, a product that we normally think, hey, if you have rosacea, stay away from benzoyl peroxide. Well, this one seems to be very tolerable for many people with rosacea, and it's highly effective. Next, I want to talk about oxymetazoline, which is an anti-redness treatment for rosacea, and could it actually modify the course of rosacea? So this is a 52-week extension of the trials for oxymetazoline. And what I want to point out is that this kind of baseline redness pre-dose and then post-dose. So if you look at week 4, before the dose, about 20% of people have had kind of a meaningful improvement in their rosacea. And then once they get the medicine, it goes up to like 70%. Great. But look what happens at week 26 and week 52, it goes up to 43%, 50%. So it seems like over time, even before you put on the medicine, before the medicine has a chance to act and make this go up even higher, that people's redness is decreasing just with this continued use over a year. And so might that continued use of medicine is telling those blood vessels, hey, calm down. We don't need so much blood flow and redness here. Might that actually help them get reset a bit to overcome that neurovascular hyperreactivity that's leading to that redness and rosacea? Might we actually modify the course of rosacea? Something really interesting to look into more. And then finally, how should we classify rosacea? A lot of times we had these old categories of like papulopustular, erythromatous-telangiectatic, phymatous. Is that actually the right way to do it? And what I would say is no, we should focus more on phenotypes than on these strict classifications. And that's because when we put ourselves in these boxes, we don't allow people to kind of cross and go between them. And really, our treatments are directed at morphologies, not at phenotypes. We don't have a papulopustular and an erythromatous-telangiectatic treatment. We have treatments that are good for persistent erythema, for flushing, for telangiectasias. We have treatments that are good for papules and pustules. We have treatments that are good for phyma. And so by focusing on the actual things that you're dealing with, is it redness? Is it flushing? Is it these broken blood vessels on the skin called telangiectasia? Is it kind of pimple bumps, inflammatory papules and pustules? Is it the nose getting bigger, phyma? Or is it some combination? We can pick treatments that directly address those morphologies rather than putting ourselves into boxes where we might not think about a really important treatment for this person. And so focusing on morphology rather than subtypes can be a really helpful strategy when it comes to taking care of people with rosacea. Well, that's what I have. Thank you all for your attention. I hope this was a helpful discussion. If you found this interesting, please pop that like button and consider subscribing to the channel for more acne and rosacea content. Until next time, see ya.